Welcome to this PCR webinar dedicated to the consistency of coronary intravascular lithotripsy across calcium types, genders, and over time. My name is Emanuele Barbato from the Cardiovascular Center Aalst in Belgium and from the University Federico II in Italy. This afternoon, I'll try to address with you some of these learning objectives. If you can have the first slide, please. So we are here to discuss and understand in-depth mechanisms of action of intravascular lithotripsy in order to optimally apply this technique. Secondly, we aim at learning about the most suitable indications to IVL in order to optimize clinical outcomes when treating different types of calcified lesions. Thirdly, we would like to appraise the longest-term clinical outcome data of coronary intravascular lithotripsy from the Disrupt CAD III trial. And last but not least, we aim at highlighting the most recent OCT data analysis from Disrupt CAD Trials series to discuss the efficacy of IVL in eccentric versus concentric calcified lesion. We have an outstanding panel of expert operators and excellent speakers. Let me just introduce you to Margaret McIntegart and Javier Scanet, who are connected from their respective countries. They couldn't make it today to be with us in Paris. And here with me, Flavio Ribicchini from the University of Verona. A special thank to Flavio. Why? Because not just because he made it and he is with me here in Paris, but also because he selected a very interesting case, which will be the core business of our discussion today. I'll hand over the word to you, Flavio, and please, let's start with the video.
Thank you, Emanuele. Hello, everybody. It's a good way to start with a practical case. We did 1 year ago in May 2020 in the peak of the pandemics in Verona with my friend and colleague Gabriele Pesarini. It's a relatively young lady, 66, diabetic, obese, hypertensive, who came with chest pain at rest with some changes at the ACG in the anterior wall and a minimum spot of troponin. You see that the echo is not very good because she's overweight, but it's enough to understand that the contractility is normal and there are no segmental abnormalities either. She did a coronary angiogram. We found a single vessel disease of the LAD, so we decided to go with PCI after a discussion in the heart team. As you can see, it's an interventional procedure performed from the right radial artery with a 6-French access, an ABU 3.5 guiding catheter. And the image shows you immediately which is the problem. It's this shaggy image, radiolucent at the proximal part of the LAD with a good distal vessel and some bifurcations.
Thank you very much, Flavio, for this introduction. It's a nice kickoff. Why don't we display the first question? Please be encouraged to interact with us via the chat box, and you will see popping up at a certain point in time in this webinar key questions to you. So what would be your procedural strategy in these patients? You heard the history, you saw this little frame of coronary angiogram. Do you think this image is a thrombus or a calcified lesion on the proximal LAD? Or would you need additional information before moving further? While you take your time to reflect upon this question, I'd like to hear the comment from Margaret and Javier. Margaret, what are your thoughts?
Thanks, Emanuele, and great case. So I agree with Flavio's plan to treat this lesion with PCI. It's a single lesion in a relatively young patient. I think that angiographically, I'd be very suspicious that this is a calcific lesion because even on the angiogram, before the contrast injection, we can see calcium in the vessel wall. So my plan here would be to try and image this lesion up front if possible. It looks quite severe, so that might not be possible, but that would be my plan to try and further assess the calcium burden.
Javier, what is your thought?
Oh, absolutely, absolutely. From on top of what Margaret has mentioned, obviously sometimes the clinical scenario gives also an additional hint on whether you may have a thrombus or not. I think that you have to be more careful if the patient is extremely obese, for example. I mean, sometimes you may have difficulties in looking into calcium, but we fully agree that the next step in this particular lesion, in order to prepare it and to plan it, will be to perform intracoronary imaging.
That's very well said, by the way. We already have comments from our colleagues. Ahmed is mentioning that, according to him, looks like a thrombus. Margaret made your comment on this, but you see colleagues are still doubtful. Ali, he says that is calcium. So I think we need to know more, Flavio. If you can go on with the video and tell us what you did next.
We go immediately. This is the first thing to guess what is inside the artery. And if you suspect it's calcium, you should go with intravascular imaging. This is the Eagle Eye Philips IVUS catheter after crossing with your workhorse wire. My preference, it's the old Pilot 50, but of course now you have better or more modern, not better wires. You see the IVUS catheter from Philips has a very good pushability. It's not low profile, but has good possibility. And as we suspected, it did not cross the proximal part of the LAD, confirming that it is a brick of calcium in front of it.
That's a good point, Flavio. And now what are we doing? Let me go back to Margaret and tease her a little bit. IVUS did not make it. Perhaps it's in his hands that did not make it. I'm sure in your hands would make it to cross. What would you do next, Margaret?
Okay, so we have two options here. One is we try and probe the lesion with a balloon to see if we can cross with a balloon, which might be possible because we know the Eagle Eye has a slightly bigger profile compared to the other IVUS catheters. So that's one option. And then obviously your other option is you think it's uncrossable, you assume it's balloon uncrossable, and you use a microcatheter and you consider rotational atherectomy. But we haven't really tested yet to see if it's balloon uncrossable, so I would test it with a balloon.
That's a good point. Thank you very much, Margaret. Javier, it is a common belief that if IVUS catheter doesn't cross, it's per se already an indication to more advanced plaque modification technique. What would be your practice in this case?
Yes, I think that, perhaps the skeptic will say it's a very hard thrombus. But my impression at this particular point is that what you have already probed with the IVUS catheter is that you have a lot of calcium ahead. That in itself will guide you what to do next. I agree with Margaret. But you could also image at that particular point. Don't lose the chance of imaging and bringing it back, because we'll give you additional information on what are the neighbor segments.
These are all great suggestions. Let me add one more suggestion from our colleague here who says, do non-compliant balloon, Flavio, and then rotational atherectomy. That is his suggestion. Let's see what you did in the video. Let's go back to the video.
Yeah, the balloon is the first step to do something, because the IVUS is not crossing. We want to see what is there. And so the balloon is the option to test the plaque. If the balloon opens a little bit, you will be able to do anything, rotational atherectomy or IVUS. And as you see, a 2.5 semi-compliant balloon open up. And then we upgrade with a 3.5 non-compliant, and it opened up. So in a certain way, we created a lumen inside the lumen. So we enlarge, and now you can see angiographically the image looks even worse, more scaring. But now we know that there is diameter enough to cross. If the balloon does not pass, then you think about rotational atherectomy. But we have a 0.14 wire, we went with the balloon, and now the IVUS tell us what is the problem. It's a huge calcific plaque, totally asymmetric on the left side of the image, with a huge amount of calcium. But now we have a lumen, so the next step is to decide how to continue. And you can continue with balloon-based technologies, because you could cross with a 3.5 non-compliant and with the IVUS prop. This is the co-registration, show that there are two important side branches, two diagonal branches. The distal one is after the plaque. The first one is just in the middle of the calcified plaque.
Thank you very much for this additional piece of information. Why don't we display the next question to our colleagues? Please reflect on this in this point. Now we've got our intravascular imaging. Many of you in the chat box have asked for it. Now we got it. What do we do with that? Because we have to be consistent. Now we are learning something from imaging. Do you think that with the level of plaque modification achieved thus far, we are ready for stenting, or do we need something more? While I let you reflecting on this question, I'd like to ask first the opinion of Javier. Are you happy with this plaque modification achieved so far? Would you do more? Would you stent?
No, well, first, I mean, I must say, I was surprised by see how eccentric this calcific plaque is. And I guess my guess was that there would be lots of calcium, but I could not imagine it was so eccentric. And of course, you have to really deal with this large amount of calcium, because as Flavio has highlighted, it's more than 180 degrees in some areas, and you really have to modify this calcium to get stent expansion.
Margaret, what are your thoughts?
Yeah, so I think this is one of these lesions you have to be very cautious about, because the balloon looks like it expands, but I bet you if we came caudal, the expansion would be eccentric. And I think you could be fooled into proceeding to stenting here and end up with a very underexpanded stent. So I think we need to go on and do some further calcium modification.
Javier, I think there is quite of a consensus here that we are not just ready to do stenting. We need something more. In addition, what we learned from IVOS is that there is an important degree of eccentric plaque calcification here. Do we have data telling us or supporting specific indications, specific treatment strategies?
Yeah, it's a very timely time to make that question, because as you will see in the slides I'm going to show you, we have now the first big evidence coming from a large data set. If I can I show some slides? A large data set coming from the Disrupt CAD sub-studies using OCT. All this data has been put together, and I believe that is the most compelling evidence we have obtained in vivo about the presence of calcium in coronary stenosis and its modification by intravascular lithotripsy. You can see that in total there are something like 262 lesions included in this study. And in this and the next slides, I'm going to show you the data that has been obtained by grouping the lesions in lesions that have up to 180 degrees of the circumference of the vessel with calcific plaque with OCT. As you can see, very accurate technique to look for calcium. Then from that to 270 degrees, nearly to 360, and then circumferential 360 degree of calcium. First thing that you can see is that in all these lesions, and geography will be telling you that there is a calcific plaque, but only intravascular imaging will be able to give you this information. So the first thing I can tell you is that in all these lesions, in the Disrupt CAD studies, there were no differences in the procedural characteristics of the treatment. So the effects of IVL that you are going to see in the next slides on these different subgroups of lesions according to the extent of calcification and calcific burden are not influenced by differences in the procedural technique. And here are the first observations that I think that are very important. First thing is that after IVL, the minimal stent area and the degree of stent expansion observed with OCT was similar across all these different subgroups of calcium involvement of the arterial circumference. I think that this is important. And these two cases illustrate this. You have on the top, you have a typical eccentric calcific plaque in OCT. You can see it here. And then you can see the cracks, the fractures that have been generated by IVL, and then a very nice stent expansion after plaque reparation. Below, you can see a circumferential calcific stenosis. Again, you can see fractures. Probably you can see more fractures because you have more plaque to see. That's something that is interesting. But the good thing and what matters is that the degree of stent expansion is similar to the other non-concentric calcific stenosis. And here you can see the visible calcium fractures with OCT in all these different subgroups of vessel calcification. Of course, as I mentioned, you see less. You see more in the 360 degrees or concentric calcific plaques, but probably that's because you have more plaques to examine with OCT. The fact is that you see them in all, as an average, 3.2 fractures per lesion. But what is very important, and I think that is a very important message, is that irrespective of the number of fractures that you can see with IVL, and irrespective of all these different subgroups of involvement of the arterial wall with calcium, you observe similar minimal stent area and similar degree of stent expansion after IVL when you implant the stent. So that speaks, Emanuele, about the fact that probably you have an in-depth modification of calcium that is, is probably caused by IVL, and that goes beyond the degree of resolution of OCT.
Thank you very much, Javier. That was a very nice and very useful overview of the available data. So Flavio, we are becoming better. We learn more and more what to do. Just to brief you on what's going on here on the chat, there are some initial suggestions on doing intravascular lithotripsy, also from our colleagues. Why don't you give us a further hint on what happened during the video?
Obviously, Javier has already told us. I mean, this channel we created with the balloon is not enough to expand well our stent. So we decided to definitely continue with the vessel preparation. You see the angiogram. There is a clear asymmetric distribution. We tried with a 30 millimeters long balloon, but because we want to know exactly how long this is and whether the distal part of the second diagonal is involved or is not involved in the diagonal. So we put a second wire to protect the second, the first diagonal, which is involved in the lesion, because we decided to go with a balloon-based approach. As I said, we have a lumen. We can cross with the stent, but the stent will not be well deployed. So this is the preparation of the shockwave balloon. It's the 4-0, 12 millimeters long. It's important that we get out all the air. The connection is very intuitive. This is, of course, single use. This part of the system is single use. It runs on your wire, the 0.14 wire, and this is, of course, major advantage. You see the second part of the system is connected on one edge to the generator of energy, so this is non-sterile, and it will be your technician to make the connection. And the second one is sterile and plugs into the catheter. You see how easily the catheter navigates now inside the lumen of the vessel, and when it plays at the position where we want to deliver the energy, we inflate the balloon low pressure, 4 to 5 to 6 atmospheres, so this will not create further damage, and we press the button and we start delivering the energy, 1 cycle each second with the maximum of 80. And you can see how the 4-0 balloon is not totally expanded, confirming that it is a very asymmetric distribution of the calcium. When we want to go a little bit distal, we saw contrast exiting the balloon. So it's clear that the balloon was totally ruptured. But an IVUS run will give you the explanation, or at least what we consider to be the explanation. You can see there at time 7, this kind of, in this moment, you can see time 7, there is a kind of sharp knife in the plaque, very asymmetric, very irregular. Probably that was the cause of the balloon rupture, despite the low pressure. It's a large balloon, it's a 4-0, and so we could not complete our vessel preparation. This is in detail where you can see also the effectiveness of the treatment, because now it's clear that there are fractures in the plaque, but there are also these sharp parts of the plaque that could damage also the balloon for expanding the stent or further therapy. So what to do now?
These are all excellent points, and actually there are a lot of information to discuss here. I'd like to start sharing the slide and going stepwise, because there is a lot of interest from our colleagues in the chat. The first question that is recurring here is when to use intravascular lithotripsy, especially as it pertains or vis-a-vis other advanced plaque modification tool, for example, vis-a-vis rotational atherectomy. That's a very important question, and I think it's our responsibility to try to help our colleagues to place correctly these devices. So let me start from Margaret. When would you use intravascular lithotripsy?
So I think the lines now are even more blurred than they were when we first got IVL, because now with the data that's emerging that it's effective in eccentric as well as concentric calcium, and as we'll discuss a wee bit further on, even nodular calcium is becoming the lines between where each device can be used are a little more blurred. I think the true lesion in which we still can't use it is the truly balloon uncrossable lesions, where I think rotational atherectomy is still your first choice. But I think this case is a nice example of where IVL is useful. So we have a large vessel. Flavio's created a large lumen with his initial balloon, so we would need a big bar to make any further impact on the lesion. And also it's allowed him to protect that first diagonal side branch that he's obviously a little bit worried about. He can keep his wire in the side branch. So I think this is a nice example of where IVL is very useful.
Thank you, Margaret. Another question, Javier, that is coming from our colleagues is, how would you use intravascular lithotripsy balloon? What is the best way to do it? For example, one of our colleagues is asking us why you didn't start with IVL in the first place in that case. So instead of doing first balloon pre-dilatation and then IVL, why you didn't go with IVL right away? What is your advice on this? What is the best way to use the shockwave balloon?
Yeah, I think that I will have follow the same approach than Flavio performed, because typically if you are unable to cross with an IVUS catheter, it is quite unlikely that you will be able to negotiate the IVL balloon. Remember that it is still not a balloon, a conventional balloon. It's a device that has a balloon, but it is not an angioplasty balloon. And therefore the profile is a bit larger. I think that I will have performed exactly like Flavio has done, using a small balloon. If I will see, you know, any point that the balloon was not dilating immediately after being able to cross with the IVL, I will go for it. So the message, in a way, in a nutshell, is I will not try to first go to large balloon dilation. I will just, you know, open a channel for the IVL balloon and then we'll perform plaque preparation first. That would be my message, because I believe that if you already try to go with a high pressure balloon, etc., you are already causing damage to the vessel that perhaps can be minimized if you increase the compliance of the plaque by IVL.
Actually, what Javier made, Flavio, is a very good point. When we try to do an aggressive balloon pre-dilatation, there is a concrete risk that we would do an extensive dissection of the vessel, while IVL is exactly preventing this risk. Why don't you explain us a bit better? How does it work, the technique? What are the pros and cons?
Thank you.
Perhaps we can have the slide to help you on this.
Yeah, we have three very important concepts here. We can try to expand further the lesion with a non-compliant balloon. You take a 4.5, you go 20, 24, 30 atmosphere. These might be effective, but this is not the safest way to do not only dissections, Emmanuel, but also coronary perforation, and in case like this with very asymmetric distribution of the plaque, coronary rapture. And a coronary rapture in a proximal LAD is, of course, a very severe complication. We have the material we need to do better. One question was, why don't go with rotational atherectomy? Well, rotational atherectomy, it's a wonderful technique. But first, you have to change your wire. You have to put the 0.0009 wire, which is not really a very friendly one, until you get used, and even after you get used. Then the rotation creates heat. The heat stimulates platelets, and of course you have certain risk of creating some thrombosis. This is not frequent in a big vessel, but it is one of the shortcuts of the technique. Then what you ablate, it's embolized. Of course, are microparticles, so normally not a problem, but in small vessels, long lesions in patients with impaired LV function, so with microvascular dysfunction, these might create some low flow, ST elevation, and you are in troubles. Other thing, we have a diagonal branch that we have protected because we thought on a balloon-based technology, you cannot leave a side wire to do rotational atherectomy or orbital atherectomy. This might be taking as a disadvantage of the technique. Actually, you don't need to protect a side branch when you do rotational atherectomy. Being based on rotation and plaque modification and not on smashing and crushing the plaque, you will not protrude the plaque into the side branch, so it's safe to do rotational in bifurcation, but you have to get rid of the idea of putting the side wire. Last, of course, rotational atherectomy or rotational devices in general in tortuous vessels might have complications like dissections in the distal parts of the vessel and sometimes perforation. All these can be prevented with good technique, but good technique requires experience, and experience requires training. And the learning curve of rotational devices is not flat. It takes time and dedication. If we go instead to the option that we selected for this case, which is a balloon-based technology, we see that we have the wire in place. This wire is okay. You can leave your side wire, the one we put on the first diagonal, and you just push a balloon. This balloon, as Javier said, is not low profile, but we have created already an adequate lumen to navigate, and you saw how easily it went. Then you don't need to do anything else than pushing the button. There is no heat, so there is no thrombosis. There is no high pressure, so there is no risk of dissections or perforation. So it's a very, very safe alternative in large vessels like this one. So these are, Emanuele, the main differences in between a rotational and a balloon. And last, the balloon is large, so it will apply its energy in the superficial and the deep part of the plaque. Rotational will rotate according to the size of your bar. If your bar is 175, which is already quite aggressive, and your balloon was a 3.5, very likely you will not create a larger lumen than that. So in this case, rotational atherectomy would be totally useless, unless you use a huge bar, more than 2 millimeters, but of course, the bigger the bar, the more frequent the complications. While with the IVL technology, you will be able to break also the deep part of the calcium. This, I think, it's the summary why this device is so appealing and so friendly, because you don't need practically a learning curve. If you want to know how it is done, you need 3 components. One is the generator that I said before, stays at the side of the table. And this, of course, is a single use. It's not single use, it's a single device you use each time. The second one is the connector that has a non-sterile switch that your nurse will connect to the generator. And then you have the sterile part with the button that connects 2 plugs to the catheter. The catheter for the coronaries is 6 French compatible, and as I said several times, it runs along your favorite wire. The different sizes go to 2.5 to 4 millimeters, and the length of the balloon is 12 millimeters. There are other 2 balloons, the S4 and the M5, which are designed for use in peripheral arteries, so renal arteries, subclavian, femoropopliteal, are also the iliacs, because the last generation, the M5, goes up to 8 millimeters, and the length is 60 millimeters, while the M4 is 40 millimeters long. Of course, these are for peripheral use with the same technique, with the same concept. You see here how it is done. It's important to remember that the markers of the balloon do not correspond to the markers of the emitters. So you have to take this into account when you place your balloon at the desired site. Of course, you can go after a first inflation farther or closer in the vessel, but this is the right position, and you see now in the slide, in the cartoon, you inflate the balloon, as I said before, low pressure, so low risk of dissections or vascular rupture, and you start giving the energy for pulses that sparks each second for 10 seconds, with a maximum of 80 pulses for catheter. And this last cartoon shows you what I think it's a nice concept of this meeting today. In the right part of the slide, you see well-distributed calcified plaques, which is concentric, 360 degrees. And on the other part, we see what is the case of today, which is a totally asymmetric distribution. What this slide wants to show you is that in the more homogeneous distribution of this concentric calcified plaque, you will get, let's say, an easiest result without the need of using all the pulses, the 80 pulses of your catheter, because the distribution of the energy is homogeneous. On the left side, what you see is that after 60 pulses, you still don't have enough microfractures. We don't know. There is no diagnostic tool to know whether you have done or not enough microfractures, because these microfractures cannot be seen by angio, but either by IVUS or by OCT. You need micro-OCT or autopsies. So what we advise is that in the case that we have presented today, where the distribution is so uneven and deep, you should be patient and use all your pulses until you are done. And as in our case, we had the first balloon which raptured. So we did not complete the IVL treatment. So very likely we have to work harder. Now, I want to hear your opinion on how to proceed with this case.
Thank you very much, Flavio. This is indeed, for me, an eye-opener. I learned a lot from this slide. We should not try to escape the question and the issue, actually, that occurred during your procedure. The IVL balloon ruptured. Is there any experience in the group here with this kind of situation? Is it the case that Flavio used the balloon not correctly, or is it something that can happen? And if it happens, I mean, how to manage, Margaret?
Yeah, so I think, like as Flavio nicely illustrated in his IVUS, I think that usually the balloon ruptures because you've caused modification of the calcium and you've created spurs or spicules of calcium that then cause the balloon rupture. In my experience to date, I haven't had a rupture used without actually having delivered therapy. It's usually like Flavio's case, where I've delivered maybe 30, 40 pulses and then it ruptures. So I think what happens is you modify the calcium, it becomes spikier, I suppose, and it punctures the balloon. And I think, as Flavio also illustrated nicely, the important thing obviously is make sure you prepare the balloon thoroughly so you don't get any air embolization down the coronary artery if you're dealing with a heavy calcium burden.
I'm curious to hear Javier's opinion on this. And what would you do next, Javier?
Well, I mean, first, it's true that we had some ruptures of balloons, but that's something that doesn't come as a surprise to us because we are working in such a harsh environment. I mean, this type of calcium spicules are frequently in these locations, and we've seen, non-compliant balloons, of course, punctured as well by these. But I must say that also I haven't seen a rupture for quite some time. I think that the new generation of the IVL balloon is actually more robust in terms of the plastic, and probably that accounts for that. So the next thing is that, of course, I mean, what we typically do, we pay a lot of attention to IVL when we are performing the delivery of energy. I'm sure that we will hear more about this. And we will pay attention to the degree of expansion of the balloon, of the IVL balloon, which, you typically, even when you inflate it at 4 atmospheres, you see how with every hit of energy, there is a gain in luminal diameter. So I'm very curious to see the next step of Flavio's cases.
Thank you very much, Javier. I have a very interesting comment from Ahmed, which is nicely preparing the overview that Margaret is going to present us shortly. This is for you, Margaret. Balloons do rupture in calcified speculated lesions like balloon granuloplasty. This makes dissection. So I guess the question here is it safe to do IVL when we see these specules, these calcified nodules? Are there data that you would like to share with us, Margaret? And perhaps we can have the slide.
Yeah, sure. So if we go back to the OCT pooled analysis from Disrupt CAD, the Disrupt CAD studies, Akiko Mahara did a really nice analysis looking at the nodular versus non-nodular calcium cases. So nodules are caused by fragmented calcium platelets and fibrin, which forms a mass that protrudes into the vessel lumen. And these are categorized into either healed nodules, where there's a smooth, thick, fibrous cap over the nodule, or irregular, eruptive calcified nodules. And what Akiko found in the pooled OCT analysis was, as I think a lot of us see clinically, that nodules were more common in the right coronary artery. But interestingly, what she also found was that most of the nodules were associated with underlying concentric calcium. So in 60% of the cases that had a nodule, the arc of calcium was over 270 degrees behind the nodule. And then actually in over 90% of the cases, there was at least 180 degrees of calcium deep underneath the nodule and the vessel wall. And interestingly, when they looked at stent outcomes and they compared the nodular lesions to the non-nodular lesions, they found that the MSA, the minimal stent area, and the mean stent expansion was the same in both subsets. What this slide illustrates here is the two OCT images to the left. What they found was that in 77% of cases, the nodule was able to be deformed by the IVL, resulting in concentric stent expansion. And in 23% of the cases, there was less deformation of the nodule with eccentric stent expansion, but still with adequate minimal stent area. And interestingly, in the nodular lesions, there was actually more visible fracture and a higher number of fractures per lesion.
Thank you very much.
So Emanuele, just to follow on, so what they concluded from this was that it didn't matter whether you had nodular or non-nodular calcium, you still achieved the same mean stent areas of expansion, but also interestingly, the thinking is maybe that this is because nodules are associated with this deep arc of concentric calcium at the base of the nodule, and maybe what is happening is that the IVL is actually fracturing the base calcium as well as the nodule itself, allowing increased compliance for the vessel wall to accommodate the nodule as you expand your stent.
Reassuring data, Margaret. Thank you very much. At this point, I think we are quite ready to know what you did next, how you solved the problem.
Okay. Well, it's clear we are dealing with a young lady with a single vessel with a complex lesion of the LAD. This lady could deserve a mammary artery. So we have to do a good job to be competitive with the mammary artery. We did dilate, we did use IVL, it broke, but we know it's not enough. So we took another new 412 shock wave balloon and we did the 80 pulses. And you can see what Javier was saying, the difference in between 1, 2, and 3, how it slowly grows, how it dilates farther, how we prepare better the lesion. Then we go with the stent, which is a little bit undersized because it's sized on the distal damage, the distal diameter. So it's 3.0 because we want to expand it proximally to 4.0 after we make sure that the distal part of the vessel is not damaged by dissections. This is the first run after IVL 80 pulses plus and the stent, and you see that it is a quite good expansion of the stent, except in the proximal part where you still need to go, and we went high pressure with a 4.0. And indeed, what you see on the right side of the longitudinal reconstruction of the IVUS, it gets better, it gets bigger, but in any case, the asymmetric calcified lesion stays there. The angiographic image is quite reassuring. The side branches are patent. We think that we have done a good job, and we decided to stop the procedure and plan an angiographic follow-up after 1 year.
Actually, the body language was quite clear. You were happy. You said, stop. We don't go any further than this. And actually, indeed, you did a good job. But then the next question is, how long does it last, this good angiographic result? Do we have, in other words, long-term follow-up data reassuring us that what you achieved, Flavio, acutely stays for a long time in such a good way? We have now nowadays available the Disrupt CAD III data that represent the largest and the longest clinical follow-up data available in patients treated with IVL. They were recently presented at TCT meeting. You see 384 patients were followed up to 1 year, and they will be further followed up also for 2 years. MACE rate. Remember, this was a very high patient risk profile. These were patients with increasing rate of diabetes, elderly patients with peripheral vascular disease, with renal failure. Nevertheless, the clinical outcome, as expressed here as major adverse cardiovascular events at 1 year, was quite good, considering the baseline position of these patients. In addition, you see a bump at the very beginning that is self-telling. of the complexity of the procedure performed in these patients. And you will see in the next slides where most of this bump is coming from. Cardiac death on the left, reassuring. High-risk patient population, we are in the range of 1%. TVR, less than 10%, so around 6% at 1 year. And myocardial infarction, up to 10.5% at 1 year, but most of it accrued within the first month. So it was peri-procedural MI, in other words. Let's look at secondary outcomes. All-cause mortality, 1.8%, TVF, 11%, stent thrombosis, amazingly low considering this high-risk patient population, 1.1% at 1 year. And here we come to an interesting subgroup analysis. You see that there is basically no difference across different subgroups that were analyzed, with the only exception of patients with longer lesion, more than 25 millimeters. And you can expect that when you have the combination of heavy calcification in long lesions, you might have side branches that might occlude when implanting long stents. So this is indeed an intrinsic risk factor of the patient that we have to take into account. 1 year TVR, no major difference across subgroups, also reassuring. And I think that all in all, we can be quite happy with the data at our disposal, Flavio. So if you acted according to what the data are telling us, we should expect good 1 year outcome in this patient. And I'm sure you have the clinical follow-up of this patient, and also something more than that.
That's the reason why, Emanuele, we decided to prepare this case today, because it's very important to give information on the... Well, 1 year is not long term, but you know that most of the events happening after a PCI, they occur within 12 months. So the patient interrupted dual antiplatelet therapy after 12 months. We called her, and he agreed to electively to perform an invasive assessment of the result. Can we please see the film so we get into the details? She came in our outpatients clinic. You see that there is a progression on the marginal branch, but the LAD is not only patent, but looks widely open, with the calcium sitting there still, but with large lumen on the LAD, and no impairment of the flow or new stenosis on the side branches, the first and the second diagonal, the one who is pinched in the stent, the second one was what spared because we stopped with the stent before. We did a physiologic assessment just to make sure that there was nothing we could not see angiographically within the vessel, and you see that both FFR and IFR are largely negative, and despite the angiographic progression on the marginal, it's negative. This is a little bit accelerated image because it's a long run of IVUS, but you can see that the stent distal is very well expanded. There is absolutely no neointimal regrowth, and you see in between time 11 and 3 that the big mass of calcium still sat on the stent and pushes it a little bit, despite the lumen is very large. And the information we get with OCT is much clearer. You see the stent struts in the distal part with a widely round shape, but at a certain point it becomes kidney shape with a part of the plaque pushing inside the lumen. So this nodule that we could not overexpand with either high pressure balloon of IVL remains there, although you see very well the difference in between IVUS images, the black hole where the plaque is, and the clear calcified plaque on the top right part of the proximal LAD, still there after 1 year, but it will be with a very nicely widely patent stent with a large MLE and without any neointimal proliferation in it. So a very safe result, physiologically acceptable. It's a diffuse disease. The patient is doing great, is under single antiplatelet therapy with, I don't know if aspirin or clopidogrel, and this is the imaging you get inside the vessel. Outside, by angiography, it looks great, but this is what we get in. And I think this is the issue of our next discussion, Emanuele. If we have to do something, if we are happy with this uneven distribution of calcium and the asymmetric form of this D-shaped stent at 1 year of the procedure.
This is really an excellent case, Flavio, a great outcome in this patient. I think it's high time now to address the many questions we received from the colleagues. Really, I have to thank everyone who's significantly contributing to further highlight and discuss this important topic. Let's try to address one by one. And I'd like to start from Margaret again. There was one of the questions that dealt with the cracked calcium arc. So in other words, this colleague was asking whether leaving this calcified, cracked calcium arc would be a nidus for thrombus formation. So in other words, even if we put a stent, would this put at high risk of thrombosis these patients? Do you think there are data on that? Do we need to do anything special with antithrombotic therapy? What are your guesses on this?
Yeah, so it's a really interesting question. So after any calcium modification, when we fracture the calcium, does it make it a more thrombotic stented lesion? It probably does, and I suppose that's borne out through the fact that TVF is higher in calcific lesions. There's a lot of data to show that now. There's not specifically very high rates of stent thrombosis, but obviously increased retreatment of the lesions compared to non-calcific lesions. Well, I think there is some sub-analysis data of the antiplatelet studies to show that in complex PCI, including calcific disease at longer duration of dual antiplatelet therapy, shows some benefit in terms of MACE during follow-up. So I tend to treat my calcium cases with longer duration dual antiplatelet than I do my more simple lesions.
Thank you very much, Margaret. Now I have a question to Javier. Javier, one of the colleagues was asking whether there is any concern to use intravascular lithotripsy within the context of patients with acute coronary syndromes. In other words, when we see thrombus, can we use IVL or cannot we use it? I mean, what's your position?
Well, I mean, obviously, first, I mean, we don't have, of course, this particular point dedicated studies answering that particular question. But what we know is, of course, that achieving, optimal PCI in the context of an acute coronary syndrome is an important aspect of it. I think that my reaction from a practical perspective is that if you find someone with heavy calcification at the point of in the middle of the night, in a STEMI patient, you should try to, of course, obtain a good result. But if for whatever reason you find that there is extensive heavy calcification that cannot be addressed at that particular point because you don't have the proper technology to do that or whatever, you should achieve a 3-me-3 perfusion and then reschedule the patient for dedicated PCI using a technology like IVL, for example, where you could achieve a good result. So there's no substitute. Say the reason that the patient comes with acute coronary syndrome is not a reason for indulgence in terms of saying that you can achieve a suboptimal result with the stenting. I think that that's something that perhaps, Margaret can comment as well.
Yes, I understand as well, Emanuele, that there's actually a planned data collection in a study, and specifically in ACS, because obviously the balloon is very usable in that environment for all operators who have to deal obviously with calcium increasingly in the middle of the night or on the weekend. So I think that data will be very helpful for clinical practice.
Thank you very much. I have a technical question to Flavio. There was one of the comments, actually the colleagues are so active on the chat that the list of questions is going down and I have problem to follow them. But it was, I think, Birgit or Brigitte, I'm sorry if I do not pronounce it correctly. He or she is telling us that if balloon rupture occurred is because you inflated too much, the first shockwave balloon. Because she says if you inflate up to 6 atmospheres instead of following the recommendation of going first at 4 and then a little bit at 6, you would have not seen balloon rupture. So can you please explain us once and forever what is the correct technique to use this balloon when you are within the coronary artery?
Well, she is right. You should start with 4 atmospheres, and giving 5 to 6 does not create a mechanical improvement of what you get. So what you need to have, it's a good the balloon well opposed to the artery wall, but it's the energy that does the job. It might be that we did it very, very quickly. It was my colleague, it was Gabriele, it was not me, so it was not my fault.
It's always someone else.
But I think that this also happened to Margaret and Javier, so it might happen. I mean, I think any kind of balloon, you know, the tires of your car can get a hole, so it means that there is always something that can make a hole in your balloon.
That's very well said. Another technical question, Javier, for you. Is there any advice on the size of balloon to pre-dill before advancing the IVL? We know that in the Disrupt CAD series of studies, up to 50% of lesions were pre-dilated with small balloons before advancing an IVL. Do you have a good suggestion for our colleagues, and for me as well, by the way, on which size the balloon should have before entering the IVL balloon?
As an average, we consider, you know, a small balloon, 2 millimeters, for example. That could be, you know, something that is reasonable for a vessel that, you know, is 3.5, 4. Certainly, again, the aim of using a balloon is to facilitate the passage of the IVL balloon. It's not to try to dilate the lesion. I think that that's the message that we should send to the colleagues, because the evidence we are getting also from OCT and from the fact that it works in nodular eccentric lesions is that you have an in-depth modification of the structure of the calcium that makes it more plastic. And therefore, the chances of having a profound disruption of the vessel wall decreases if you have performed IVL before, you know, going to the large size. And regarding the size of IVL, we always use a 1-to-1 balloon ratio. Balloon to artery ratio.
Very good point. Another important question to you, Flavio, which is the following one. Superficial versus deep location of calcium. Does it influence in a way the usage or the adoption of these or the other advanced plaque modification tools?
Emanuele, you know, we have been treating calcified lesions for many years, and for many years the only thing we had were balloons, then scoring or cutting, and rotablation. So this difference in between superficial and deep came out since we have OCT, because when you have IVUS, the difference is quite difficult to tell, and since we have this option. For 30 years, we have been doing our job relatively well with rotablation. Now we know better which is the problem, because we see better with OCT and because we have the option of going deeper in the calcium and the plaque because of the energy of IVL. Now that we know that, being myself an operator with rotablation for many years, when I see an asymmetric, very deep calcified plaque like this, I do prefer to go with IVL, provided that you have made sufficient lumen to go with the balloon, because as Javier said before, the profile is not that. So if you cannot cross with a 2.5 balloon, you will spoil your IVL catheter and you will need to rotate. In some cases, we may leave this for discussion later if it comes out, you might need 2 systems. But the concept today is superficial calcium is very well treated with rotational devices. When you have these very asymmetric and very deep and thick calcified plaques, evidently IVL, this is what we have tried to show you today, is the easiest and the most effective and safe way to do it.
It's actually interesting how the questions become more experienced and more advanced by the time we go on with our discussion. And colleagues are asking very important questions. Just along the line of what Flavio was just discussing, Margaret, one of the colleagues is asking, would you perform ad hoc intravascular lithotripsy in a failed rotablator case? Or let's say not a failed rotablator case, in a case where plaque modification after rotational atherectomy would not be complete, would not be sufficient. Would you do that?
Yes, and I've done that several times with great effect. So I think there are undoubtedly lesions where you need multiple calcium modification devices, and they often will have incremental gain in a case. So I think that's where imaging is very important. So use your first device, re-image, and make sure you've modified adequately. And if you haven't, choose another device and complete the job.
And then there was a very weird question specifically to you, Margaret. I think you're the best one among us to address this. can we use IVL in female patients? I would say yes. I don't see anything wrong, but would be nice to hear from you if we have data on this.
Yes, it's a very interesting question. So we've known for a long time that in the presence of calcium that women do worse. So they have more procedural complications during PCI and they have more MACE during follow-up. They're obviously in all the studies, the women tend to be older and have more CKD than the male patients. We in our centre, we collected some data on over 700 rotablation cases and we compared males to females, and it was very clear there were significantly higher procedural complications in the women compared to the men, and much higher MACE rates during follow-up in the women compared to the men. So really interestingly, from the pooled analysis from Disrupt, there's a sub-study looking at gender, comparing men to women. It's the first calcium study to show there's no difference between male and female patients. So procedural success is the same, complications are the same, and long-term inpatient and 30-day MACE rates are the same between men and women after IVL therapy. So I think that's very encouraging.
That's actually very reassuring, Margaret. Javier, don't think you would escape a special question, because I also have one special for you. Ahmed is asking whether IVL can be used or has been used in SVG, saphenous vein graft, and in instant calcified lesion, instant calcified restenosis. Any thoughts on this?
Yeah, let me start by the second one, because even when it is an off-label indication, certainly is for us, one of our, say, techniques of choice when you have chronically underexpanded stents. You know, sometimes you have the patient that comes typically with the stent failure, and you see that the stent is grossly underexpanded, and then you interrogate with OCT, you see that there is huge calcification. And sometimes it's because the operator was unable to actually expand completely the stent at the time of the index procedure. And in this situation, IVL is a fantastic tool. I think that is simpler than laser, for example. That is the only other technique that can interact behind the calcium that is behind the stents. In the acute setting of implanting a stent, you should, I believe, only use IVL as a bailout device. If for whatever reason a stent has been deployed and you are not able to expand it, in that situation, you know, it may be licit to use IVL as a bailout device, because otherwise, if you do it routinely, you may ruin, you know, all the polymer and anti-proliferative cover. And finally, regarding saphenous vein grafts, I will be very cautious, because, you know, these are complete different type of vessels. And in this situation, trying with IVL in a saphenous vein graft that is heavily calcified, it may be perhaps more like performing any other type of PCI, you know, can be bound to more possibilities of conduit rupture.
Thank you very much, Javier. You know, colleagues are continuing asking questions. I think we are heading the end of this session. But before closing, allow me to give the final word to Flavio, who did a great job by selecting this case. Any final consideration from your side, Flavio? Any comment you want to convey?
Well, thank you for giving me this opportunity. I think that we have shared with you very practical issues. But if I might add something, and Margaret mentioned this before, we don't have to think that these kind of devices are there in the shelf to be used once in a while in the chronic patient, in the old patients. These devices could make the difference also in our daily practice in acute coronary syndrome. Our main mission is treating coronary syndromes in acute phase, STEMI, non-STEMI. It might happen because of the age, getting older, patients more complex, calcium is there, and PCI gets more difficult. It might be that you cannot manage to open your artery, the culprit artery, and you need to be proficient with the use of these devices. The older, we need to teach the younger, and they need to, this is not a procedure for old people, very experienced. You need to train, you need to learn, but this is life-saving. So I would leave this as a final message, if you allow me.
I would still be I would still like to think that I'm among the younger ones who could still learn from you.
No.
But
if you are here with me, you are not.
So I think we are ready for the final remarks. Let's pop up the slide. So first of all, thank you very much for your proactive interactions with us in the chat box. You really contributed significantly to make the discussion very lively. Let's try to find some point of consensus. Highly calcified resistance coronary stenosis benefit from advanced plaque modification techniques despite angiographically sufficient balloon dilatation. So let's not be overconfident when we see this balloon nicely expanded, because there might be more underneath. Secondly, intravascular lithotripsy, when properly used, has shown to be effective equally in concentric and eccentric coronary stenosis. And we heard from Margaret this recent sub-study in calcified nodule. Even there seems to be good outcome data. And third, and last but not least, 1 year angiographic follow-up confirms good clinical outcomes after intravascular lithotripsy. Actually, we've got the angio follow-up from Flavio. We've got the clinical follow-up from Disrupt CAD III. So I really think the technique is mature enough to be used in our daily clinical practice when applied in a proper way. With this, I'd like to thank very much all my colleagues, Margaret McIntyre, Javier Scanet, Flavio Ribichini. I'd like to thank the sponsor, Shockwave Medical, who made this possible. And I'd like to thank PCR crew, who made all the logistics here and the technical support fantastic. Thank you very much, and follow us on in the next series of PCR webinar.